Dr. Song is somebody that I met probably, I forgot to look it up, but I think it's 12 years, 12, 13 years. Met him down in San Diego because that's where he lives. You came from UCSD, you spoke to, we had a group in San Diego at the time, and he came in to speak about Parkinson's and neurological attributes and things that have to do with Parkinson's. So I've known him a long time. He is one of those doctors that, like many of you, you would want a conservative doctor, I think. Not somebody who just revs up the pills and says, you know, stuff on this, you know, so they have side effects. Everything has side effects. You know, let's try another one of these, or let's take this one and add it to this one because maybe we can help this one get better. I mean, it's just, he's not that kind of a guy. And so I like that about him. I like the fact that he has actually made lemons out of lemonade. Anybody get that one? Okay.
Okay.
You got to pay attention here. You don't get this only once. But he's made lemonade out of lemons because he has his own neurological problem. When he was somewhere under the age of 50, if I'm not mistaken.
Yeah, 47.
47, that's under 50. Used to be.
Okay.
Okay, at 47, he had a stroke. Now that is a neurological conundrum. So here he is back practicing his field of medicine. He is a fellow in neurology, which he's gone beyond neurology and became a movement disorder specialist. Now for those of you who have gone to Eisenhower and saw Dr. Hermanowitz, Dr. Hermanowitz is a movement disorder specialist, but we also know that Eisenhower did not renew that contract. So Dr. Song is here tonight to talk to you, to give you information that you will certainly enjoy and absorb. But further, we're going to talk about some possibility that our organization is working with him and probably Maria or whomever we can to bring him into the valley telemedically. That means that he could be sitting in San Diego. He doesn't have to drive 2.5 hours to come up here and then drive 2.5 hours to go home. He could be sitting in San Diego and he could be viewing you medically and treating you over television or over the camera. That means that someone else in that room is someone who understands what he needs and how to best treat you. So if tonight this is something that you think you would like, I need you to come back to me. Call me, not tonight, but in the office, call me and register your support for helping us get this accomplished. This all takes time and money, and I don't have either one right now. So I really, truly need your support in helping us bring telemedicine to the Coachella Valley, if we can do that. Now, having said all of that, the room is yours. This is your meeting. You ask the questions that you want. If you don't ask them, nobody's going to ask them for you. And Dr. Song, thank you for being here again.
Well, thank you so much. Okay. Thank you. Thank you for so many of you come on over here. And so, what I'm going to do is just talk about Parkinson's in general. I'm going to cover the some basic things that in terms of what we know about Parkinson's and how the conventional way that we go about treating it, and also an approach that I usually use in how to make a decision about some of the medication that we use as well. And so I know that, as Joe has mentioned, is that because medications can't treat everything, that we do look for other therapies to augment things, because the medications can only do so much. But the medications have gone through clinical trials, and we have what we call level 1 evidence for their efficacy. But the thing that you ought to realize when you see a neurologist, particularly a movement disorder specialist, is that even though we know all the things that can work, the art that is involved in deciding what is best for you individually has to be worked out between you and your neurologist that you have a relationship with, because everybody is different. Everyone is unique. Everyone has unique problems, and because of that, that affects the medications that may be better for you and may not be necessarily the best for someone else. So just keep that in mind. And so what I'm going to cover then is kind of broadly speaking, some of the issues that go through our minds when we approach a patient, make a diagnosis, and make a decision in terms of treatment. And so because it's a broad overview, there's a lot of information, okay? And so if we just as I go along, just stop me if you have any questions, because I'll be happy to answer them, and that'll make it more interesting for you all anyway. And the other thing is, because I have so many slides, I kind of want to run through them real fast, and it might go too fast. And so just go ahead and just slow me down so I can go over some things for you, okay? And then at the end, of course, we can ask some more questions. And I think the question and answer time is probably very useful for a lot of people. And so we'll try to spend some more time at that point, okay? I think last time, because we got so late, I didn't spend a whole lot of time about the last portion of the slides last time I did this. And so I'll just keep that in mind, because this could easily be a 2-hour talk, just so you know. But no, I'm not planning to, but it will depend upon what kind of questions and answers we kind of get into, okay? But again, if you don't understand something, go ahead and raise your hand, and I'll slow down, okay? Okay, well, okay, let's see. Okay, so yeah, I was trying not to turn my back in front of you, and so that's why I was kind of going on the other side there. But so I'll just go there. So yeah, so I hope you don't mind that you have this cord in between me and you, but this is just the reality of what's going on. Okay, so as you can all hear me, right? So the volume is fine. Okay, good. Okay, so let's get started. And so, as you all know, a lot of famous people have gotten Parkinson's disease. And so, of course, Michael J. Fox, more than anyone, probably has brought up a lot of publicity for this. But it affects a lot of different people. And, of course, the predominant people who do have Parkinson's are older. But young people like Michael J. Fox are also affected by Parkinson's. And so we'll just keep that in mind. So, even this past month, I had a brand new patient who had the symptoms that started when she was in her 30s, and she has a kind of an infant with her, and that was kind of interesting. So I never had a woman that young have Parkinson's as well, but that does happen. So just realize that it does cover a wide age gap. Okay, this is just to emphasize the fact that we have a lot of things that look like Parkinson's, okay? So we call them Parkinsonisms or Parkinsonian syndromes, okay? They basically mean the same thing, okay? And so in other words, what that means is that there are a wide spectrum of things that can look like Parkinson's, okay? And so among this, the most common is Parkinson's disease, which is up here, which will account for about 3/4 to 80% of the cases. And so that's a Parkinson's disease, and I'll go through that in terms of how it's defined in just a little bit. But I just want to emphasize to you, there's a lot of things that look like it, but it's not Parkinson's disease, even though it can be a Parkinsonism or a Parkinsonian syndrome that can look like Parkinson's, okay? These include things that are secondary to something else, either by medication, typically the dopamine blocking medications that are used in psychiatry, also medications that may be used to help you with gastric motility. And the other things are toxic infectious causes that can also cause Parkinsonian syndromes. And we talked about the structural things, if certain things like the tumor or the fluid around the brain that circulates, if it gets blocked, it can cause something that looks like Parkinson's. Of course, as for my neurologist, because we go through the exam very carefully, there are things on the exam that distinguish those syndromes from Parkinson's, but those are things that can look like Parkinsonism in the sense that it affect the gait, and so it look like it in a lot of ways, okay? Just so you know, there are things that are called Parkinson plus syndromes, meaning they have other things that are usually not associated with Parkinson's, but are prominent early on. And those are situations when you may have A very big problem with drops in blood pressure, as in multiple system atrophy, or very significant problems with eye movements. And also, if you have a very strong component of dementia going on, that there are other diseases that have the Parkinsonian features as well, but these other things. And so those are distinctly other diseases that overlap in their appearance, look like Parkinson's, okay? Okay. And then, just so you know, there are some other rare things that affect younger patients that are inherited that also can look like Parkinson's as well. These are things that including Haller-Warden-Spatz disease, the very young onset Huntington's, as well as some other things like neurocandocytosis and Wilson's disease that can also have some similarities, okay? Okay, first of all, as you all know, is that as one gets older, the risk of getting Parkinson's increases as you get older. We all know that, you know, in the older population, there are more people that have Parkinson's. You know, in the younger populations, it's less likely. And so certainly there is some effect of age in the disease process. We don't know exactly how age affects it, but it's certainly involved, okay? And so, do you have a question or? No? Okay, okay. And so, okay. And so the other next thing is that just a reminder that the Parkinson's disease is named after James Parkinson, who was the first to publish a good description of the main features of Parkinson. And this was done in the early 1800s. And so since that time, obviously we've made more progress in that, but the basic features of Parkinson's disease is approximately basically the same thing that he described, okay? So he did a very, very good job in describing the disease itself. And so what are the classic hallmark features of Parkinson's, okay? The first thing that I bring up is bradykinesia, or slowness of movement. And so if you notice that I brought that up first, I didn't bring up the tremor. I know that a lot of people have focused on the tremor as being the distinguishing feature of Parkinson's. It can be, however, it is not the distinguishing feature. The distinguishing feature is slowness of movement, okay? So we're talking about a hypokinesia, which is a reduction in the amplitude of movements, and also akinesia, which is the absence of movement or freezing. Those are also aspects of bradykinesia. The other thing is rigidity, which is a stiffness. And that rigidity neurologically is a specific term. It is an increase in tone, but it's a special type. It's very different from spasticity. It is an increase in tone, is independent of speed and independent of direction. It's there resisting movement in any direction when you try to move, okay? And then the third feature, like we all know, is the rest tremor. And it is a rest tremor, not any kind of tremor. It's a tremor that occurs when you're relaxed and not doing anything. And so Parkinsonian tremors are by nature a rest tremor and not an action tremor, okay? So not all tremors are indicative of a Parkinsonian syndrome, okay?
What is pill rolling?
Pill rolling, way back when before we had tablets and before we, way back in the 1800s, the way they made pills is like this. You know, when you get this substance, you put them in and you go like this to roll a pill before you sell them. And so the classic description of the rest tremor looks like you're pill rolling. It has this kind of movement, okay? But of course, that is just a characteristic of it, but you know, it can be other types of movement too. So that's not the only type of movement. If you had a rest tremor that's in your jaw or in your foot, it wouldn't be pill rolling. No one rolls a pill with their mouth or their foot or something like that. But that's just because of the way the hand moves, and so it has a kind of appearance to it. Okay. Okay, and so this is just visually. I know that a lot of times a picture is says a lot, can describe things a lot better than the words themselves. And so obviously you have a guy here who's walking very slow, okay? And so this, you can see the components of bradykinesia, very slow movements, but also the hypokinesia in terms of the small steps, okay? All right? And then the other pictures here are just going to re-emphasize the point that we're talking about rest tremor again. This person is relaxed and he's shaking. And so this one, the tremor in this case is not pill rolling, but it is the tremor at rest though. So that's, the tremor at rest is the important thing, okay? That's the feature that you have to keep in mind. And just because I know that a lot of people with other types of tremors get confused with Parkinson's, but just so you know, this is an action tremor. This is a tremor with action. And so that is not Parkinson's. So that's more of a typical tremor from essential tremor, which is totally different from Parkinson's, okay? All right? Okay. All righty. Then let's go on then. Okay. Then we've known for quite a long time over the past few decades, when a Parkinson's patient passes away, we can do pathology and look for certain characteristic changes in the brain that have been classically used to define Parkinson's and is still used as a gold standard. And meaning in the brain stem, the substantia nigra, which is the black substance here, substantia nigra means black substance, okay? This is in the normal brain, and this is in the patient with Parkinson's. You see that there's a lot less of the black stuff, okay? That means they have fewer substantia nigra neurons, okay? This is a high power view. These are the normal neurons, and this is in the patient with Parkinson's. And you have much fewer neurons in that case. And this is a hallmark of pathologic inclusion within the cells. And so that's also a characteristic of Parkinson's disease. That is the classic Lewy bodies. And so you hear that every now and then in terms of Lewy bodies being linked with Parkinson's, okay? And then the other thing to keep in mind, it's been very important over the years, is that Lewy bodies contain a lot of what's called alpha-synuclein, okay? That's a protein that is ubiquitous within the nervous system. For some reason, it gets accumulated in these Lewy bodies. So there's a lot of research in the area in terms of what alpha-synuclein may be doing that might cause the disease, okay?
How do you test for that? How do you test for that?
Well, that test is, we obviously can, that's when you're dead, then you could cut the brain and do a stain for that.
But for the what accumulates that causes it? How do you test for that? And
Well, that's
the patient's alive.
Yeah, that's $1 million question that we don't know. Okay, so that's what all the research is about. And so one of the theories is that it might be pesticides or something like that we're doing research on, but we don't know. That's the thing. And so we know that there's genetic causes also. So genetic causes within the body, your body just makes too much of it, or you can either you make too much or you can't clear it fast enough. Okay. And so there are families where they make too much, and so those families, it's a problem of making too much alpha-synuclein, and so that happens in those families, okay? But that doesn't happen to everybody though. But that's where all the research is in to try to figure that out.
So Lewy body is more or less a genetic-oriented disorder?
No, Lewy bodies is a pathologic inclusion that's characteristic of Parkinson's. It can be genetic, but also in people who do not have any genetic history whatsoever, you'll still see it there also. Okay, so just the pathologic sign that occurs in Parkinson's, okay? And there's all for many, probably decades now, the majority of people felt the Lewy bodies was something bad, okay? But now there's arguments that maybe Lewy bodies are actually something good. It might be the body trying to fight the accumulation of alpha-synuclein and just trying to compartmentalize it someplace safe. Okay, so there's a lot of arguments about what it does. Okay, and so those sort of things are still being worked out. Okay. Okay, and so I'm just going over here just to show you what we in a movement disorder clinic would go through to make a diagnosis, okay? And so the thing that you have to realize is that the diagnosis is still clinical. There's no magic test or a test that you can use that will clinch a diagnosis. The diagnosis is based on everything, the history, and the examination. And when we do that, we just go through step by step a process here. We look for 2 hallmark features, and we always include some bradykinesia. It's mandatory. So in other words, I'm saying that you don't have to have a rest tremor to have Parkinson's. And I'm sure that there's some of you who have Parkinson's that have never had a tremor, right?
Yes.
And so, okay, and so you all know that. And so I got to tell you that some doctors don't even know that, okay? And so, but it's true, you know, you could have Parkinson's without a tremor. And so that's the point, okay? But so what's mandatory, the only one that's mandatory is that there's some slowness somewhere in the body, okay? Okay, yes?
So when you're diagnosed with it, does it have to be by a neurologist or can it be your general doctor?
Okay, what I would say is this, is that even among neurologists, most neurologists are not very strict about the criteria, okay? So what I'm saying is that if you're not strict, I think your positive predictive value of being accurate and being on right it really decreases a lot, okay? And so what I'd say is that other than neurologists, I don't think I know of any other doctors that would do this. They would just say, they look at you and say, oh, you don't move your face very much. You must have Parkinson's. You know, they made the diagnosis, okay? If you do that, you know, that's kind of iffy there, you know?
So if your general doctor diagnosed you with it, then should you go to see a neurologist?
What I would say is this, is that, of course, you know, remember earlier I said, among all the things that can look like it, the majority is still Parkinson's. So if you play the odds, they can still be right, of course, right? There are things that you can do to confirm it, okay? And then including the response to levodopa and the history in terms of whether it fits with that or not, okay? And so if the physician goes through all that, then you can be pretty sure of the diagnosis though. But if there is any doubt whatsoever, I strongly do recommend seeing a neurologist because they are the only ones that spend the time to actually go through all this to try to figure it out.
Well, and I'm going to add to that, and that's why we introduced Dr. Song, who has his fellowship in movement disorder specialists. So there are a lot of neurologists, we have them here in the desert, and many of them haven't got a clue what Parkinson's is really about. So it's really, really, really important that if you're going to a neurologist, you have that understanding that they have the knowledge of Parkinson's. Otherwise, you need to go to a movement disorder specialist to get that second opinion.
Okay. Yes?
Now, the bradykinesia, is that shuffling that's not necessarily slow? I mean, you're saying bradykinesia is slow movement.
Okay, you know, but I use bradykinesia broadly speaking, so that it could be the components of either hypokinesia or akinesia. So it includes freezing and all that, and so all those features of slow movement, I'm just lumping it all together. Okay.
And the shuffling.
Yeah, the shuffling gait is part of it.
And when you're saying response to levodopa, what time frame should you see a response?
You know, the thing is here is that, again, you know, how that is tested will determine that, okay? Because obviously, if they never give you much of anything, you could be on it for months or years and never see a thing on it, okay? So the doctor has to actually spend the time to actually titrate the dose up week by week and see if there is a response or see if there's an adverse response, and we have to back up, okay? So you have to go through that in order to see. And so my experience with a lot of Parkinson's patients that have been seen by other doctors is that a lot of doctors, even neurologists, don't want to spend the time to go through all that. And so they just throw in a dose and kind of leave it at that, and they may make adjustment a year later or something like that. You know, for me, when I see a patient, I want to know as soon as I can do they respond to levodopa or do they not? Because I think having that information makes so much an effect on everything else, because it's going to tell you whether it's going to be a typical pattern in terms of over the years, or if it's going to be an atypical pattern that's going to be very different. And so you might as well find out as soon as you can.
Okay, am I correct in hearing you say that a more proof way of diagnosing is when you give levodopa?
Mm-hmm.
So then how long would it take for levodopa to get into your system before you would actually know the diagnosis?
Okay. It depends on the dose, and everyone is different in terms of what dose they need to see a response. That's why I'm saying that a neurologist has to take the time to go through the dose of the medication.
Oh, okay.
But we always start low because some people, they can't tolerate it. It makes them so nauseous that they throw up and they can't handle it, okay? And so we always start low. And some people don't need very much. You could give them one pill and they feel normal the next day. That can happen in one day.
But there are other medications, like my husband was on Stalevo very, very, very early.
Yeah.
So how do you connect
No,
Stalevo?
but Stalevo is still the active ingredient is still levodopa.
Oh, okay.
It's the same thing.
Same
Okay.
thing.
It only has an extra enzyme inhibitor to boost it up, and so that counts as the same thing. Okay. So I'm saying that any levodopa containing product is the gold standard that we use in terms of establishing responsive or no responsiveness.
And then the symptoms would diminish?
Yes, yes. You know, in terms of being levodopa responsive. But I got to tell you though, but that is not absolute, okay? I wish a lot of things was a definite yes to no answer, but it works 80% of the time. So you could still be in the 20% where it doesn't work and still have Parkinson's, okay?